This content is independently created by BloodStream Media. Novartis is our exclusive advertising partner. Welcome to the P&H podcast. Thanks for being here.
We're going to start things off today by slowing things down. We've got a special episode tonight for all our PhDs and MDs and ABCs that wear white scrubs after Labor Day.
Looks good on you. Yeah.
Our favorite early birds and night owls who went to school longer than my dog has been alive.
That's a long time.
You know them. You love them.
Doctor.
Can you get a doctor? Because I need a doctor.
Hey, Doc!
Today, we're talking about the provider and clinician experience with P&H with none other than our favorite doctors, Dr. Chonat and Dr. Weitz.
We'll be spinning this tune for the next 25 minutes, so suit up or sit down, buckle in, and boogie down. This is the P&H Pod.
Thanks for joining us.
I gotta say it, I think I could have had a career in radio.
Well, you are hosting a podcast at this very moment.
It's just not the same thing.
Moving on.
Okay.
Today, we are talking about the unique clinician and provider experience when handling P&H.
Like with any rare disease, P&H is accompanied by its own set of challenges when it comes to the clinical perspective.
As neither Josh nor I are clinicians or providers, we have Dr. Chonat and Dr. Weitz here to shed some light on those challenges that are specific to P&H.
Since P&H is so rare, it's important to spread awareness of how to manage and treat P&H since your general practitioner probably doesn't see many cases of it.
Here are some of the key features of P&H that a clinician might be looking for.
So there aren't a lot of things that cause hemoglobinuria. So if you see blood in the urine or hemoglobin in the urine, but no cells, that's hemoglobinuria. I have one patient who had the disease for 15 years before she was diagnosed. She saw 5 urologists, and they all told her she must have a bladder cancer somewhere. And they never found it when they did a cystoscopy. And finally, she went to a new doctor who checked an LDH that was 1800. Her bilirubin was slightly elevated.
LDH is an enzyme that helps make your body's energy. If your LDH levels are high, that could indicate tissue damage.
Bilirubin is a red-orange substance made during the process of breaking down red blood cells. Testing your bilirubin checks the health of your liver.
She had a pretty normal hemoglobin, but a high retic count.
A retic count measures the number of reticulocytes in the blood.
Reticulocytes are red blood cells that are still developing.
Baby blood cells, cute.
Adolescent blood cells.
Not as cute, but I'll take it.
And having a red count that is too high can indicate serious health problems.
And they sent the appropriate blood tests, and she had P&H. Yeah, so you need to think about it. And if what your first diagnosis was doesn't seem to fit, go back to the differential diagnosis and rethink the diagnosis. So you need to look at the blood counts and look at the LDH, look at the reticulocyte count. And so many clinicians out there don't check a reticulocyte count, which are the young red blood cells. If you have anemia with a high reticulocyte count and a high LDH, they probably have a component of hemolysis and the bilirubin's elevated. So you need to think about the disease. And if they're Coombs negative, then think about P&H as an option. If they have hemoglobinuria, there are only 8 or 9 things that cause hemoglobinuria. P&H, thrombotic thrombocytopenic purpura, TTP, and AHUS, thrombotic microangiopathies, another complement-driven disease, malaria, a lot of complement activation in malaria, ABO incompatibility, bad leaky cardiac valves sometimes can cause fragmentation. The enzymopathies like G6PD and Clostridia perfringens bacteremia, which is extremely rare. I've only seen one case in my entire career.
The key features, in addition to anemia, the thrombosis, and bone marrow failure, some other things that we see are some of these patients, since in many developed countries, at least these patients are on complement inhibition, So now I think the key features that we're looking at these patients are who are having ongoing hemolysis, what we call as extravascular hemolysis in some patients who are on C5 inhibitor, or there's some patients who actually have breakthrough hemolysis, meaning they actually have breaking down of red blood cells during periods of infection or surgery or any kind of a stress. So actually understanding this intermittent hemolysis and how they may affect other organ functions is important. It's also important that we actually explain to them about some of the clinical features related to anemia and what to expect with regards to the bone marrow failure if they have. The diagnostic challenges, I think, it's a test that we can be done to diagnose PNH, has been well validated. It's available fairly widely in the United States and many other countries. But being able to send that test, if you think about it, it's key. And being able to follow up with a test and ensure the patient actually gets plugged in with a hematologist who has expertise in taking care of this PNH. Once that is set up, I feel that the care of the PNH patient can be remarkably advanced, especially with the newer therapies coming. We always encourage that these patients are plugged in with an expert hematologist, even though they could be taken care of by someone in the community.
These are some of the challenges clinicians face in diagnosing PNH.
It's not that easy.
Raising awareness of these challenges can help prevent situations like the one Dr. Weitz mentioned.
Waiting 15 years for an accurate diagnosis.
That's a long time.
And once you receive an accurate diagnosis, then begins the treatment journey.
We'll be hearing from Dr. Chonat and Dr. Weitz about unique considerations managing PNH after this quick break. This is an ad for Novartis, the exclusive advertising partner for PNH, Facts, Fiction, and FYI. Ever wonder, is my PNH well controlled, or how bad do my symptoms need to get before I talk to my doctor? You can get the answers you need at explorepnh.com. There, you'll learn that any symptoms, mild or severe, may be a sign your PNH isn't well controlled, and that because PNH is different for everyone, it's important to let your doctor know how you're feeling. So, if you want to deepen your understanding of PNH, which can help you advocate for yourself and your needs, get answers and helpful resources at explorepnh.com. Brought to you by Novartis.
And we're back.
Thanks for sticking around.
So far, we've discussed the challenges and considerations around diagnosing PNH from the clinician's perspective.
After a diagnosis comes the management and treatment of PNH, which brings with it unique considerations.
Dr. Chonat and Dr. Weitz weigh in.
The first and foremost, we want to, once they've diagnosed a patient with PNH, the second is to see if they have an associated bone marrow failure disorder. We see an associated aplastic anemia or bone marrow failure with PNH in pediatric patients than adults. If they do have a bone marrow failure disorder, they may require an immune suppressive therapy or a bone marrow transplant or other treatments.
Bone marrow failure is when your bone marrow doesn't make enough red blood cells, white blood cells, or platelets.
For PNH, if the patient does have clinical evidence or the PNH does involve in clinical symptoms, we discuss with them to see if there's any open clinical trials that the patient may be eligible for. Clinical trials are key to improve, and not only improve, but also to advance the treatment in PNH. So if they do have an open clinical trial, we try to explain and inform them of the possible clinical trials. If not, we discuss about the available FDA-approved medications such as eculizumab or ravulizumab or pegcetacoplan with both adult and pediatric patients. In addition to using complement inhibition, it's important to actually monitor. So most places have a very set way of monitoring these patients with regards to the blood tests and maybe some bone marrow examinations in some of these patients, but also frequent visits to the hospital.
Complement inhibitors target different levels and steps of the complement cascade.
They are used to stop hemolysis, which is the destruction of red blood cells.
Most patients who have very tiny PNH clones, and what the clone is if you do a flow cytometry on peripheral blood, looking for the presence or absence of the GPI-anchored proteins, so CD59, CD55. You will see that a certain percentage of the cells circulating will or will not have the complement proteins identified. The loss of the complement proteins defines the PNH clone. So some patients who have aplastic anemia have very tiny PNH clones. You need to treat the underlying aplastic anemia because that's the primary problem.
Just a reminder that aplastic anemia is when your body stops producing enough new blood cells.
If you have patients who have a very large PNH clone with evidence of hemolysis, those patients need to be treated with complement inhibition because that'll alter what happens to those cells. Now, with complement inhibition, the clones get bigger. They don't go away. It's not like chemotherapy. It doesn't make the disease go away, but it will modify the presentation of the disease so they won't have symptomatology. So things like fatigue get much better because fatigue is not just driven by hemolysis, by the hemoglobin, it's driven by the complement-related cytokines. And so it's really an inflammatory process. And we also know that the risk of thrombosis will decrease with complement inhibition as well. So we don't need to anticoagulate the patients prophylactically anymore.
Which means to slow down the coagulation of the blood with preventative measures.
It's also important that some of these patients may request supportive care, such as red blood cell transfusions. We ensure they don't have any other nutritional deficiencies. In young women that I take care of, few of them have issues with regards to heavy menstrual bleeding, so it's important to address that because we want to address in any and every way that we can optimize the hemoglobin, not just by blocking the complement with regards to the PNH-related hemolysis, but also ensuring there's no any other contributing anemia. In addition to some of the unique consideration to disease is understanding the disease, explaining to this patient, and also having a very patient-tailored approach is key in managing this disease, especially because we have newer treatments that's coming our way.
These are just a few of the considerations clinicians and providers must take into account when managing patients with PNH.
Over the course of treatment, there are some challenges clinicians face in providing optimal care for their patients.
Dr. Chonat and Dr. Weitz explain.
Some of the biggest hurdles in initiating the care for PNH patients is discussing if any open clinical trials available and what fears they may have. Not every patient may actually be eligible for such clinical trial. Then the second biggest hurdle, especially if you're starting a commercial drug, is ensuring and discussing with the insurance and getting approval from the insurance.
These are very expensive. And I'm saying this up front because this is what drives people to treat or not treat. Not the disease process, but the cost. So if I have a patient who's diagnosed in the hospital, I can only use something like eculizumab. I can't use any of the other agents because of their cost.
While there are FDA-approved medications, there still remains a significant copay for some of these patients. While the sponsors do help offset some of those costs for some patients, it still does not completely take away some of the economic challenges. So the economic burden of some of these patients still remains a biggest challenge. That not just the total productivity loss in these patients, and some of these effects that we see are maybe even larger in lower income countries.
It's a pharmacy issue. It comes out of their budget. So we'll treat with eculizumab, and then when the patient's ready to go home, then we can make a decision about whether or not to move them to a long-acting inhibitor, which per dose is more expensive than eculizumab, but in the long term is less expensive. Or to put them on a C3 inhibitor, which can be done at home.
The home treatment of these medications has certainly helped, but getting some home treatment set up might take some time to ensure we have the infusion team who can go to the patients' homes on a regular basis and provide these medications.
Expenses can often be a huge barrier in what treatment looks like for the individual living with PNH.
But with a little help from your physician, there are ways of finding cost-cutting solutions.
We also can change the dynamics so that the patients can be treated at home rather than treated at the hospital, which may cost more. So now nobody knows how they're going to price the factor B inhibitor, the iptacopan, so we don't know what that cost will be. So the treatment of choice in the modern era for PNH, for anybody who has any evidence of hemolysis, or they have thrombosis, or they have any of the other symptomatologies, is complement inhibition. That's really the treatment of choice. And which one depends on the scenario, whether they're in-house or outpatient. So those are the issues that we have to deal with.
The other biggest challenges we have is being able to ensure that patients actually get these medications, remain compliant, and also ensure that the patients are responding to these medications. So able to do frequent visits to the hospital, especially some of these patients I see have to travel 2-3 hours to come to my clinic. Just because some of this testing that we do may not be available close to where they live, some of the physicians who manage these patients are not comfortable in the community with regards to some of the nuances of PNH. So it's a long way to learn and educate the providers, the patients, but also there's some of the biggest challenges that remains to be addressed are the economic burden in these with regards to such treatments, and also ensuring that we can provide the best care for each and every patient.
We are extremely grateful to doctors like Dr. Chonat and Dr. Weitz for keeping cost limitations in mind when crafting a treatment plan.
Before we wrap this up, Dr. Chonat and Dr. Weitz highlight some of the most important aspects for healthcare providers to consider when working with PNH patients.
For most of the hematologists out there, this may be their only PNH patient that they have. So there are a lot of questions that the patients may have that they may not be able to answer. So I would strongly recommend that they send those patients, at least for a second opinion, to a large academic center. Because I think it's great that they want to take care of the patient. That's fine. We always send the patient back, unless the patient doesn't want to go back. But, knowing the disease and having experience with the disease counts a lot. The best centers, for example, in Europe, in England, they have 2 major PNH centers. All the patients are followed there in either center. In France, they're all followed at one center. And I think, and similarly in Germany, you want to be where somebody has expertise in the disease. And that also may open up the possibility of participating in clinical trials, etc.
With regard to medical care, I think it's most important is to address the available medications, the clinical trials for the patient, understanding what the patient prefers, and also the mode of administration. So finding that optimal drug, because since we hopefully in the next few years will have many more options that may be available for these patients. And choosing the right drug for the patient is really key in discussion with the patient, because it's important the compliance of the patient, especially some of the newer medications, which may be oral medications. The compliance are being questioned in terms of how compliant some of these patients can be. So I think it's important to consider treatments based on these patients. With regard to the emotional support, I think it's key to address issues related to the disease by itself, ensuring that the fatigue is addressed on a regular basis, ensuring some of the symptoms related to hemolysis are addressed because they add to the mental well-being. And we ensure that these patients are routinely seen by our social workers, psychologists, and we also ensure that the caregivers and parents are also have an opportunity to discuss these with our support team. Additionally, I always encourage our patients and family members to sign up for patient groups such as the AAMDS and other such groups, so that they can actually get support, emotional support, and also understanding the disease better from other fellow patients or caregivers.
The treatment journey with PNH is going to look different for everyone.
And raising awareness of your options as a clinician and as a patient is critical in seeking the treatment plan that's right for you.
Next week, we'll be discussing new horizons for PNH as treatment and care evolves over time.
As always, thanks again to Dr. Chonat and Dr. Weitz for providing their outstanding insight.
And we'll see you next time on the PNH Podcast.